Greetings and welcome to our webinar today, which explores community and aged residential care responses to COVID-19. For those who don't know me, my name is Lenore Russell and I am the Principal Advisor, Services and Standards at Alzheimer's New Zealand. Today we'll be hearing from Lee-Fay Low, Sara Charlesworth, Wendy Taylor and Lenore de la Perrelle. We've got lots to talk about, so let's get into it. It's been 2 years since the global outbreak of COVID-19. And here in Aotearoa, New Zealand, we're now facing the peak of our Omicron wave and our fight to keep people safe and weather the storm. The impacts of COVID-19 have been vast. During the last lockdown, we moved quickly to protect older, vulnerable people in aged residential care. And while this undoubtedly helped control the spread of the virus, it also led to isolation from family, whānau and friends. And it increased feelings of loneliness on both sides. So it begs the question, how can we best support the rights and the well-being of residents in aged residential care facilities during the COVID-19 outbreak? And how do we balance this with also ensuring that health and safety needs are met? Our expert speakers today will be telling us about a study which reviewed COVID-19 policies in countries with high vaccination rates, like New Zealand, and they'll also be sharing the Australian experiences of managing COVID. Before I introduce our speakers, just a few reminders about this webinar. Your video and your microphone are turned off, but we still want to hear from you though. So if you'd like to ask a question, please use the Q&A box on the right-hand side of your screen. Please do remember to let us know which speaker your question is for. We will have time for questions at the end, so as questions pop into your head, pop them into the Q&A box so you don't forget them. And before we begin, just a quick reminder for our speakers, please mute your microphone and turn off your camera when you're not speaking and turn them back on again when you want to join the screen. And finally, just to let everyone know that this webinar will be recorded and we will be sharing a link to watch again after we finish today. So let's get underway. Lee-Fay Low is Professor in Ageing and Health at the University of Sydney. And amongst the numerous other research she is involved in, is the lead researcher to work to produce policy to inform residential care visitor policies in countries with high vaccination rates. Lee-Fay today will be followed by Sara Charlesworth and Wendy Taylor. Sara is a Professor of Work, Gender and Regulation at the Royal Melbourne Institute of Technology. Her current research focuses on good aged care across Australia, Canada, Scotland and New Zealand. Wendy Taylor has been researching and consulting on workforce issues for more than 20 years. Her areas of interest include job quality, dementia and well-being. Following Sara and Wendy will be Lenore de la Perrelle, Research Associate at Flinders University. Lenore has developed award-winning services and staff training programs to support the well-being for people with dementia. So I'll leave it over to you now, Lee-Fay.
Hi everyone, thanks for coming. I'm coming to you from Sydney, Australia, and I'd like to start by acknowledging on behalf of the Australian speakers, the traditional owners of our country as well. For me, I'm coming to you from the lands of the Gadigal people of the Eora Nation, and I'd like to acknowledge elders past, present and emerging and any First Nations people present here at this webinar today. In March 2 years ago, when COVID started, almost all countries locked down nursing homes. So when I say lockdown, it means complete visitor bans, no family visits and no one leaving the nursing home, no residents leaving the nursing homes. And there was really government guidance behind this, because what we noticed was that once COVID-19 entered a nursing home, it was really hard to prevent spread, and that the care home fatality rates were really high. Some in a few countries they were low, but in some countries up to a third of COVID deaths were nursing home residents. Over the last 2 years, there have been multiple studies now showing the harms that have come to our residents, our elders, because of these lockdowns. So residents were really lonely and they were isolated. In some places, lockdowns went for months and months. So for months and months, they didn't get to see anyone familiar to them besides staff and their loved ones. And staff were often wearing full PPE or partial PPE, so you couldn't see faces and you didn't understand what was going on. In some of these lockdowns, residents were confined to their rooms, depending on, I guess, the stage of COVID outbreak. There are multiple studies now reporting that residents experience cognitive decline. We know that half or more residents in nursing homes have some form of cognitive impairment or dementia. And without that ongoing stimulation and activity, they got worse. And perhaps the mood also made them worse. We also have well documented now physical declines. People weren't walking as much, they weren't going out, there were perhaps less activity groups, there was less reason to get out of bed and move, and we saw this deconditioning and physical decline happen as well. So also really consistent reports now of increased behaviours. You can think of behaviours as expressions of unmet needs, but certainly people were more agitated, they were more upset, they were resisting care, if you think of it, resisting care more. So people were behaving like they were not happy while isolated. And to go with that, there's also really nice data now showing increased psychotropic medication prescriptions, across these last 2 years of COVID, but particularly in times when there were lockdowns in residential care. We also have really good documentation now about the impact on families. They were really, really stressed not be able to see their loved one. They were anxious. They were really scared about what was happening to the resident, not just the resident getting COVID, but who was looking after them, whether they were being fed properly, whether they were being looked after properly, and their well-being. And I guess the impact on family was worse if their loved one had cognitive impairment. Here's some quotes from a qualitative study about the harm caused by restrictions. More than my health, I really feel that it's freedom that I've been robbed of, and I find it difficult to bear. The lack of contact. I didn't hold anybody since, I think the lack of physical contact is very hard. It's almost unhuman. It's not natural. They, the staff, take you for pawns, for children, you see. They do not ask your opinion, and it is worse during COVID. We are very easily infantilized. I picked this last quote because consistently we're hearing that residents really didn't have a say in the lockdowns. They didn't have a voice in what was happening to them. And while early in the lockdowns, the few studies suggested that residents were kind of in favor of the lockdowns to protect themselves, that across time, I think residents were kind of finding it very difficult not having contact with a family member or someone they knew and loved. And as we think about, I guess, these lockdowns, which have been going on for 2 years now, in some places on and off for 2 years now, we are also starting to think more seriously about the rights of residents. Now, the UN conventions basically say that everyone has a right to family and relationships. And we have deprived aged care residents of this right by cutting them off. And while I know that in many countries, in New Zealand and in Australia, we've had, lockdowns in the communities where we can't leave the house, but most of us have ways of communicating with people we love, even if we're stuck at home by ourselves. So we can phone someone, we can Zoom someone, we can communicate. Whereas some residents anyway, didn't have the capacity or the technology to communicate. And so when they're locked down, they have no way of getting in touch with family. And those family are so important, I guess, in supporting not just their well-being, but also their identity, reminding them of who they are. It's their, I guess, one of those really meaningful parts of their lives when they're in residential aged care and have often less agency in the world. In Australia, we had singles bubbles. So if you lived by yourself, you could, even during the full lockdowns, we recognized that mental health for people living by themselves is really important, and you could pick someone else as your buddy and kind of have one person that you could see physically. And I guess the inequity, I guess, of that was really stark for me. And as our lockdowns were lifted, the inequity, I guess, and the violation of rights became stronger and stronger in Australia between what the general public was allowed to do and what residents in aged care were allowed to do. Here in Australia, residents have aged care rights. I've just highlighted some of those rights, which are around control and being able to have a personal and social life, and about being able to take risk and kind of make decisions about independence and day-to-day life. And I think certainly in many facilities, these rights were violated. I talked about these inequities of freedom. And at one point in New South Wales, we were wearing our masks badly and going to the theatre while residents were locked in and couldn't see anyone. And I think this inequity and violation of rights, really needs more thought, because we're treating nursing home residents as not having equal rights to those of us living in community, and this is not fair. And it's like the attitude is like we should protect them because we don't want deaths to go up, but we don't care if they have a terrible, miserable time locked up. So just telling you the story, I guess, of COVID in Australia over the last 2 years, you can see that we're just coming down now off our Omicron peak, which was really significantly higher than the first 3 waves, I guess, that we had, which barely show on this chart relatively. You can see the waves as well in terms of deaths, and we're also coming down off our death peak rates, and still a large proportion of these deaths are nursing home residents. But you can see that that peak of deaths is lower, I guess, than the peak of cases, relatively. So we have learned to manage COVID in care homes better over these last 2 years. There's been reduced risk of spread if there is a single case, or what we call an outbreak, and reduced risk of death if the person has COVID. I'll just show you some data kind of highlighting this. So in the first year of COVID, there were 224 outbreaks. 44 of those were contained to 1 case, so it didn't spread further in the facility. And 33% of residents who got COVID died. In almost the second year, and I stopped at the 26th of November, mostly because that's when Omicron really started taking off. So the last lot of data I show you is the Omicron data. There were 305 outbreaks. Of these, we contained more of them, 56% to 1 case, and 13% of residents who got COVID died. In our Omicron wave, you remember that, there were so many more cases, probably 100 times more cases, almost, probably more, because our data, our testing rates, our testing data became terrible. So we don't actually know how many cases we had in the peak. But we've had 2,612 outbreaks. So almost every care home has had an outbreak now in Australia. But of those, of the many resident cases, only about 0.5% of people died. So we still had many more deaths than in the first, well, we had more deaths than in the first 2 years. And we had certainly many more deaths in this short period of time, but a smaller proportion of residents died. So we know better now how to stop COVID from spreading in nursing homes and how to stop people from dying, which means that we can stop locking people down to you know, as a way of preventing this. But there's all these other ways of preventing, of minimizing the impact of COVID. I'm not going to go through all these in detail. They've been written otherwhere. This is not a webinar, I guess, on how to do these particularly, but infection control, cohorting, making sure you have enough PPE and that people know how to use it correctly, single site staff policies, because we knew that staff were spreading it between sites, getting people paid when they were casual, so that sick pay, so that they didn't come to work. We had mandatory staff vaccinations here in Australia, and that was slightly controversial. We've seen lots of use of rat tests and other screening procedures before entry for staff and for visitors. And we've seen improved collaboration between health and aged care services to support services when there is a COVID case. Just caveating, the levels of COVID-19 transmission in the community is a major factor in the system's ability to support care homes. And during our Omicron wave, our health system and other systems were really overwhelmed. And I don't think that the system was able to support care homes, which meant that care homes were then not able to support the well-being of residents. So this is the visitor policy scan that Lynetta flagged in her introduction. We've been following care home visitor policies over the last 2 years. And over time, we've seen government policies change so that mandatory lockdowns have, decreased. Governments are less likely to say you need a mandatory outcome. And there's been a shift really in policy support for essential visitors and visiting during outbreaks. In many jurisdictions, though, many regions, the decision of how to manage this is still left to the individual home. And there's only a few country examples, for example, in the Netherlands, where the rights of residents to have visitors are being upheld by the government. I'm going to show you our Australian industry code. So this was developed by peak bodies, and it's got 3 levels of risk based on community transmission: green, which is very low risk; orange, where there is COVID in the community; and red, when there is an outbreak. But irrespective of the level of risk, the code says all residents should always have access to at least one visitor, and it goes on to define what those visitors are, and really highlights, I guess, partners in care, people who have been coming and supporting the resident, in daily care and emotional support. What we know is through COVID, through Omicron, states have had different regulations and procedures, and there's a whole lot of different visiting requirements that different aged care providers have put in, basically. So even though we have these visitor guidances, they still had full lockdowns, full visitor bans, and it's really differed. So I know Lena's going to throw me off because I'm talking for too long, but for those of you in New Zealand, please be ready. And here are some ideas of things you can do to be ready to support residents to kind of keep having visitors, because it's so, so important for them to keep having visitors, even if there's an outbreak and even during kind of community lockdowns. So now I'm going to hand over to Sara and Wendy, who are going to talk a little bit more about staffing and COVID and resident wellbeing.
Thank you very much, Lee-Fay. So I'm just going to turn on our PowerPoints and share them with you. Sorry, I'm just... okay. So hopefully you're seeing that shared, and I'll take you back to the beginning. Okay, so there are really two key studies that we're going to draw on. One is a 4-year project that's been looking at the links between decent work and good care in Australia, New Zealand, Scotland and Canada. And a second project that was investigating from the perspective of workers how best the social and emotional needs of older people using aged care services could be met. Now, both of these projects, substantial fieldwork was undertaken pre-COVID. However, they really support Pat Armstrong's major finding here that the conditions of work are the conditions of care. And we're really keen to bring consideration of the workforce into people's home care and residential care organisations' strategies. Now, in Australia, COVID has really revealed, as in many countries, but to the broader community, which is important, the impact of chronically poor pay, inadequate staffing, poor working time conditions. Lee-Fay mentioned working across multiple sites. That's because we have a model of organisation of work that keeps people on very short and fragmented hours. And we know from our study of the New Zealand system and our organisational case studies in your country that some of your working conditions are not as poor as in Australia, but we're not going to focus on those structural issues here. But because you are, in fact, facing rapidly escalating infections, we want to focus on some key lessons that we think could be undertaken from the organisational level. So I'm going to hand over to Wendy, not only because she was absolutely key in both projects and indeed the project manager of the first very large and unwieldy project, but she's somebody who has got significant lived experience as a carer of family members with dementia. So over to you, Wendy, and I'll go to our lessons.
Okay, thank you very much, Sarah, and hello to everyone in New Zealand. So, as Sarah said, you cannot talk about the well-being of older people without really looking about, also talking about the workforce and the conditions under which they work. Now, before I go into, we've got 5 lessons, it is worth noting, as Lee-Fay highlighted, we've had more deaths in aged care residents this year in the last few weeks than we've had in the previous 2 years. So we're still learning how to prevent and manage the outbreaks, but I do feel we've got some lessons. Some of them are probably what not to do rather than to do. Okay, so firstly, the lesson 1 is plan for mitigating staff shortages. In Australia, we've had workforce shortages in aged care for some time now, but now it's been described, it's a workforce crisis. The degree of shortages throughout the pandemic has been fluctuating. And often the policies that have been put in place to actually manage and reduce, contain the infections in the community have exacerbated the staffing shortages in aged care. So if I just explain a few of the causes of the shortages and how they've changed during the pandemic. Initially, we had staff shortages because a lot of staff were terrified of either catching COVID or passing it on to their family members. Then in many sites, they instituted that workers could only work on one site. Now, this step was adopted by a lot of other countries as well, and it certainly had positives for certain sites, but it did mean it increased staff shortages in other sites. Then, as infections rose in the community, we had workers getting COVID themselves, but also they were close contacts, and often they were required to isolate for up to 2 weeks initially, and this furloughed large numbers of personal care workers. Then we had school closures, so we had staff that needed to take time off to care for their or support schooling. More recently, we've got policies mandating vaccinations for staff across aged care. They vary between the states, but it is likely there will be numbers of personal care staff for a variety of reasons that are yet to be vaccinated. Notably, aged care staff, they weren't included in the government's rollout of vaccinations to aged care, which was aptly referred to as now known as the stroll out. Also, to deal with some of the extreme shortages in aged care, the Australian government contracted a private provider to provide what was called a surge workforce. The Royal Commission, however, found that a lot of the staff that were employed by the contractor actually lacked a lot of the basic skills, particularly to care for people with dementia. Today, many of the organisations, a lot of aged care providers are still dealing with a lot of staff absences and shortages. And it's been a very tough 2 years in aged care, and no doubt a lot of workers are leaving the sector. I don't know that, I can't tell you the numbers there. So we've got 5 lessons. Firstly, what can you do to minimise staff shortages? Given that overall people with dementia need stable staffing. So the first thing is vaccinate your staff and their households. We had one large not-for-profit in Australia, and I'm sure there were others. They set up inside vaccination clinics for staff. They vaccinated all staff, including all casual staff. They arranged vaccinations for home care staff and all the household members. They provided paid leave to get staff, so all staff could get vaccinated. Then there was another organisation, they provided financial incentives to get staff vaccinated. The key thing here was to support family members or household members of your staff to get vaccinated. Now, in terms of strategies, build up a bank of relieving staff. We actually saw, it was in New Zealand, where an organisation that had felt had become too reliant on agency staff. They had set up their own internal staff bank. So these staff could work across various sites, and they had found that to be particularly effective. Another home care service, they had established a pool of relief workers, but in this case, they were all their full-time workers, and they were their most experienced workers as well. So these people would be most equipped to be able to go in and work with unfamiliar clients. So both these strategies should certainly help in terms of if you're facing shortages. Lesson 2, increase the ratio of nursing qualified staff and trained frontline staff in infection control and provide time for them to use their skills. When the first wave hit in Australia back in 2020, a lot of aged care facilities simply lacked the numbers of qualified nursing staff needed who had infection control, who understood infection control. Over the last 20 years in Australia, we have seen quite a significant reduction of registered nurses and enrolled nurses in aged care homes. And now there's about 70%, often more, of frontline workers who are personal care workers. Now, the majority, not all, hold Cert 3 qualifications, which are similar to your qualifications in New Zealand. But one of the issues, and this was picked up by our Royal Commission, is often the personal care workers are working with minimal supervision. And this issue, although it was picked up by the Royal Commission, still remains a problem. So I guess the message here, your RNs, ERNs, are absolutely critical. Now, the third lesson is around allow your residents to use outdoor spaces during lockdowns. I've visited about 35 aged care residents over the last few years, and a couple of things have stood out. The first is that there's been quite a significant shift to these multi-level large facilities. And the second thing is just how much or how influential building design is to client wellbeing, but also the capacity of workers to manage residents with dementia. Residents, whether they're in dementia units or whether they're in the household units, they enjoy being outside, and they particularly like having the freedom to move between inside and gardens throughout the day. And this is regardless of the time of the year. However, many of these new buildings, they lack outdoor spaces, or where they do have, say, balconies, they're often locked, or residents can only use them if there is a staff member with them. So we've heard in both the studies that workers can find it particularly hard to engage men with dementia in facilities, and outdoor spaces is absolutely critical to this. And it also does help reduce residents feeling frustrated and bored. And both of these things we know contribute to aggression, both towards staff and towards other residents. So if you can look at ways to, if you are in lockdown, if you are having lockdowns, to continue to give your residents access to gardens and outdoors. Lesson 4 is support and provide time for dementia trained staff to use their skills. Aged care staff have consistently told us that residents crave one-on-one interactions with staff. And this is contact outside the clinical care and the day-to-day personal care. And many organisations that we see are really trying to incorporate far more one-on-one activities and recreation with their residents. But often the personal care workers who do have the dementia training or the recreation staff, they actually lack the time to actually use these skills and implement all their plans. So they'll be scheduled to help at meal times, or they'll have to jump in where there's been some sort of incident, so they'll have to watch residents. So the key point here is just as important it is for workers to acquire these skills, particularly in dementia and these meaningful interactions, you've got to allow time to actually engage in these. These are some positive examples. Certainly in one of the household models, what this organisation had done is they'd removed virtually all the cleaning tasks away from the personal carers, and even things like making the beds. And that really did free up more time for personal carers to just to be able to spend more time one-on-one with residents. Now, the last lesson is lesson 5, develop and support the wellbeing of staff as well as the wellbeing of clients and residents. Researchers are now coining the term moral distress. And this is for the experience of frontline workers where time and task have constrained their ability to provide what they consider is, the right care for residents. And during COVID, we've seen, and Lee-Fay pointed this out, as well as people dealing with moral distress, they're actually dealing with a lot more resident deaths, and they're dealing with grieving, anxious, and often angry family members on top of this. So hence they need more support. Many organisations, they struggle with how to acknowledge the deaths of residents, and also how to support staff who may have developed quite close relationships with residents and home care clients when they die. And there's often this approach of sort of silence, just so that they don't upset other residents, or they view staff distress over the death of residents as sort of unprofessional, and this really has to change during a pandemic. So what can you do? One thing, and again, we've seen these examples, institute regular supervision practice for frontline workers to develop their skills and actively support them when they are caring for particularly challenging residents or clients at the end of life. Secondly, bring small groups of residents, and we've together and with a staff member allow them to watch online funerals of fellow residents that they've cared about. And thirdly, hold small periodic gatherings every few weeks where residents, family members and staff can come together and actually celebrate the lives of residents who have passed away. So there, look, there's some of the things we've observed and some of the lessons from Australia. There's obviously many more, but I hope they're providing they're helpful in some way. Thank you.
Hi, Namani. It's a Ghana term for how you're going now. You've heard lots of information, and so I just want to talk a little bit about my experience in providing support to residents and people living in the community and their families during COVID as a social worker in aged care as well as a researcher. So I've got some information here that I'll share, and I hope that's come up now. Can people see that? Yeah. So, and I'll do it from the beginning. Can you see that all right? Yes, there we are. So I live on the Ghana land, which is Adelaide Plains in South Australia. And we were very smug up until the 23rd of November because we had very, very low rates of COVID in the community, almost no community transmission at the time. We thought we had a high vaccination rate, 78% at the time, and the government decided to open our borders to the eastern states on the 23rd of November. We'd had very few cases in South Australia. And then as soon as we opened, of course, it was just before Christmas and just as the Omicron epidemic started. So as a result, the numbers of cases in residential aged care just ballooned, and the deaths in aged care just this year are more than half of what has been for the last 2 years. So that has been quite shocking for everybody, and it was a big wake-up call, but we had been asleep at the wheel before then. We had quite a lot of lockdowns for smaller outbreaks over the 2 years. And in many of those situations, people were confined to their bedrooms for 14 to 21 days at a time, that there were no activities, no visitors, and staff were in PPE. So for people who are older, who had any hearing or sight impairment and cognitive impairment, they were shocking situations for them. And so as a result, my experience was that just about everybody in some form of care, whether they lived at home and had carers come in or lived in residential care, had a real sense of isolation. Lee-Fay has shown the evidence that came from that. But what I saw was that people with probably undiagnosed or untreated or unrecognised level of mental health problems that had been sitting in the background became much more dominant. So lots of people developed quite significant symptoms of depression and anxiety. Panic, there were a number of people who just could not cope, felt that sense of entrapment and panicked and became aggressive or reacted to further lockdowns. Some people gave up, and some people did refuse to get out of bed or couldn't see the point. And so that was incredibly worrying for families as well as the staff, and for many of the residents, they were very distressed. I had to find ways to connect, and what we found was that we were completely unprepared. Residents in nursing homes or people living at home, many were not capable or had any experience of using technology to communicate. And so found it very difficult to manage. They felt with lockdowns that they weren't allowed to go out at all, and so sat in one room at home or in their bedroom in the nursing home. So many people didn't go outside at all, and many people didn't do anything. They were sort of waiting for it to be over. So there was this sense of being unable to move forward, do anything. And so what we were saying was you've really got to send messages of love. Just positive, I'm thinking of you, I wish I could be with you. As soon as this is over, I'm going to give you the biggest hug in the world. Letters, photos, etc. And if you can visit in any situations, is to try and get the person to stand up and walk. Because what we found was that many people developed pressure wounds because they sat 24 hours a day. They did not move at all, and there were no activities. Even the staff, when they brought meals in, didn't ask the person to stand up or to move to a place to sit. They just gave it to them. There was no encouragement to do anything. People without cognitive impairment were able sometimes to do puzzles or colouring in or something that would just while away time. But it is really important to find ones that suit people with cognitive impairment and that can be used in various ways, not just put in front of a person and let go. And as we've heard twice already, the outdoors is absolutely essential. Getting people out into the fresh air, whether it's hot or cold, raining or windy, it's that sense of freedom, a sense of not being trapped, which is important. And what we found with families was many families didn't also feel very confident in using technology or had thought, well, there's no point in sending a letter. But if a letter came, it's quite possible to ask that a staff member read the letter out to the person. Once again, sharing feelings, unlocking your heart, actually saying, you know, I'm thinking about you and thinking about how it's going in that little room of yours. If it's a lovely thing, you've got a beautiful picture of Dad or our kids or something. Being prepared to mask up, wear PPE and take tests to demonstrate to the residential facility or to your loved one that you don't have the virus, because fear was significant. We suggested to families to sit down and talk to the staff or the managers in any of the services, whether it's at home or in facilities, to reassure them that you were compliant with the health requirements, and then make a list of the things that you wanted to do and negotiate with them about you know, being able to take the person out for a walk along the street, in the fresh air, into the garden, onto the balcony, any of those things, so that you could actually lower your mask at times to talk to the person if they needed to see you, rather than through a window or through a mask or a visor as well. The thing that I would say is what we didn't do, the lesson we learned was that you need to prepare. People need to learn how to use video conferencing. And once they're locked down and everybody's upset, learning then how to do it doesn't work. I had lots of experiences where people were given iPad to look at, and I was talking to the person, and if there was some cognitive impairment or any confusion about the technology, then the image on the screen and the voice didn't sort of match up with the person, so they felt it was disembodied. So a computer screen is bigger, and people sit at a computer is much better than an iPad, because people can put the iPad down and look elsewhere, be distracted. So learning how to use video conferencing well really, really helps, and practice. As Lee-Fay talked about being a partner in care, actually negotiating with the facility that you're going to be the person who comes in, that you're trustworthy, that you know how to do all of this PPE and rapid antigen testing, so that they know that they don't have to think that you're going to bring in the virus. And certainly, we've saw a number of people volunteer in the facility to actually help the staff. And there were some specific things that people did. Sometimes people were able to assist with visitors in terms of doing their PPE, washing their hands, somebody to greet them and say, it's really good that you've come. These are the things you need to do. Because lots of people not sure of how to do that. But also sometimes people were able to actually volunteer to take their family member or somebody else outdoors, because staff were overly busy delivering care to individuals in their rooms, food as well as care, and testing. And so therefore they weren't able to spend any time in actually taking someone outside. I had to agitate for one facility to take a person outside who was had a mental health problem, cognitive impairment, and his mobility had declined so much in a 21-day lockdown that he was panicking, wanting to hit people, threatening suicide. And so therefore I said to him, what would help? And he said, I just want fresh air. And so I said, you have to take him outside for 10 minutes twice a day for the next week, and don't give him any more medication. And I did, which was great. And it really made a difference to him. Just 10 minutes once a day, twice a day usually is my recommendation. So, and the other thing that was really important and what I found was that people who were in residential care or at home alone needing care just really wanted to talk about their feelings. And it's often scary to sit and talk with somebody about their feelings, especially if they're talking about wanting to die. But in fact, all my conversations with older people during the pandemic has been about death. And while some of them weren't anywhere really close to death, they wanted to talk about it. And so it was in that situation where you could talk about advanced care directives and what helped, what they would prefer if something happened, and then move back into a strengths-based perspective. Oh, okay, so what's possible today? So, you've woken up, we've got something to do today, the sun's shining, it's raining, or, the grass is growing, so let's do something. And, what would you have done in the past? What could we do now? Planning for tomorrow or the next week is a way of reassuring a person that they are still who they are, their identity is really important, and enabling them to see that there's somebody else who's able to cope with their fears as well. Families need support too. So families need someone to talk to, because often it's very difficult to see your family member or your loved one deteriorating and you can't do something about it. So it's really, really important to be able to talk to staff and saying, I'm really concerned about this. I want the person to be able to go outside. I'm happy to do it, and I want you to show me how to do it. You know, how to move from a chair into a wheelchair to go outside, from a wheelchair to a bench in the park or something like that, into the car just for a drive. You know, it's finding out how to do it and taking that on rather than expecting the staff, because as we've heard from Sarah, there's the staff will be overwhelmed and won't be able to add specific support. There's a lot to talk about. This is practical information, and I'm happy to take any questions that might come up. Thanks.
Thank you very much. Yes, now we'll have a wee look at what questions that we've got come through now. We've got one question that has just come through. It seems obvious from the experience that the lack of meaningful activity and social engagement had a massive negative impact on people's mental, psychological and emotional health. Do you agree that the role of the lifestyle, diversional, recreational therapists, different names, different countries, is critical to enhancing the well-being during lockdowns?
I think it's critical. I think it is critical. However, they're not often the staff who are in charge. And so a lot of the decisions are made on a medical or health reason, and many lifestyle staff can't do the things that they used to do. Or felt a lack of power to do the things that they would like to do. So many of the lifestyle people were the ones who were organising the iPads and the Zoom sessions, and they were really helpful. However, many of them weren't real experts on it either. So there's a lot of learning for the staff, there's a lot of learning for residents, there's a lot of learning for families.
Thank you, Lenore. One thing I'd just like to ask is the research shows that even in times of high community transmission, that visiting should continue. So I know that that's a place that we're entering now in New Zealand, and it's that how do you look after the health and safety of the residents, of the staff, when there is that high community transmission, if you're allowing visitors to come in. So, Lisa,
yeah, Lenore, it's a balance, right? We've seen the full lockdown. Even in a full lockdown, you still have outbreaks because staff will bring it in, and it's really terrible for residents and it's horrible for families. So if there is an outbreak, so in high community transmission, you should keep having visitors. You can do some safe visiting procedures, screen people, get people to rat test, really strongly encourage your families, all the things that Lenore was talking about in terms of, being about families knowing how to use PPE, for example. Visiting outdoors. You might not have families, going to group activities, but there's a big difference between no visitors and safe visitors. And so you should try and do safe visitors. And if you have an outbreak, still have families visit. One really important family member visit, make a big difference. They can help with that person. They can help, if they're at that residence in their room, having the family visit actually is easier for the staff once the family member's in there. Do you know what I mean? Like, they can help with the feeding, they can help with the person being distressed. So I think that balance, yes, you don't want a full 80th birthday party facility when there's high community transmission, but that's not what we're kind of suggesting. What we're suggesting is that you put in safe visiting procedures, which does require preparation, requires having rat tests, requires having PPE, requires having the staff knowing what's happening. But just keep that, I guess it's prioritize well-being equally to prioritizing stopping COVID getting in. And, and you need to support your staff to do that as well.
Great. Wonderful answer. And one, I understand that in Australia, and I don't know whether it's Australia-wide, you've got a visiting policy. It's actually a requirement, and that's Australian-wide?
It's their industry guidelines. So it's what the industry thinks peak bodies think should happen, but they're not being, facilities aren't being held to them. So we will see some facilities who have had visitors who keep having visitors even if there is an outbreak, and we'll see facilities who have gone into lockdown. And I've even heard facilities who don't have an outbreak, who are, you know, doing a pre-lockdown in case, like 2020. So it's really horrible for residents to be locked in their rooms.
Come through. Thank you. Look, I want to give a big thank you to all of you today for such a really engaging and informative discussion, especially, of course, to our speakers, Lee-Fay Low, Lenore de la Perrelle, Wendy Taylor, and Sara Charlesworth. I know that I'll be coming away today, and I'm sure lots of others will be too, with some great ideas for how to better support the well-being of residents and families. And you've just said that so well, Lee-Fay, that the well-being is just as important as the medical health of the residents. We know that staff do an amazing job, and it's a really, really difficult situation at present. There's no doubt about it. And there are clearly some workforce issues that need to be addressed. Right through this webinar, though, we've been given the reassurance, I think, to us here in New Zealand that we are on the right track. So thank you for that. And hopefully, though, you've given us some further ideas as to how people living in aged residential care can remain connected to family and friends. Some great wee tips there in these very challenging times. So thank you again, and hopefully we see you all again soon. It's been great. Thank you for sharing your Australian knowledge with us. Ka kite, anuia koutou. Bye for now.